So good morning once again, everyone. This is our fourth topic in gynecology module 3. Okay, so we have two topics for today, and we start with uterine leiomyoma. Once again, I am Dr. Armero. So these are our objectives for today. And since uterine leiomyomas represent as the most common gynecologic neoplasm, it is very important that we discuss the prevalence, the symptoms, and physical examination findings, how to diagnose, and of course, the management options that we have. So as you can see here in this slide, grossly, we will be able to appreciate the different sizes and locations of the myoma. It can be small, it can be a little bigger, and it can be really huge. Microscopically, we see these as fibers, okay, spindle-like fibers. So these are muscle fibers we see microscopically in leiomyoma. This is called also known as myoma, commonly fibroids or fibromyoma. These are just benign tumors of muscle cell origin. And as I mentioned earlier, this is the most common benign neoplasm of the uterus. And it can occur 80% of African Americans, while 70% of whites. So how does leiomyoma present? So again, it depends on the location. Either it's submucosal, intramural, or within the myometrium, or subserosal, in the beneath the serosal layer. So here, these are illustrations of myoma depending again on the location. It can be a pedunculated submucous myoma. It can be purely intramural, or it can be a large fundosubserosal myoma, or it can share either a subserosal with intramural component. Again, I tabulated the symptoms based on the location. So as you can see here, it is the submucosal myoma and in the intramural myoma that presents as abnormal bleeding. Also, it is important to note that in submucous myoma, there are issues in outcomes of pregnancy or fertility. Submucous myoma can cause infertility or recurrent pregnancy losses because, again, this disrupts the endometrial lining. Now, if it's intramural, it presents with abnormal bleeding as heavy or gushing menstruation. While in the subserosal, it is does not usually present with heavy bleeding. In fact, it's usually asymptomatic even when it's quite large, unless it is closely located anteriorly, and so it presents with bladder dysfunction or pressure in the anterior abdomen, in the bladder, or there are issues in bowel function as well if it's more at the posterior. Again, there can be no symptoms of pain or bleeding, but it can present as an abdominal protrusion. The uterus looks large because of the big circles brought about by the myoma. Now, risk factors. So which one of the factors decreases the incidence of uterine myoma? Is it early menarche, nulligravidity, gravidity, obesity, or smoking? So in the book, these are the enumerated risk factors. Okay, now here in black are the most common risk factors that we can identify in majority of our patients. As you can see, there is an increase in estrogen exposure especially in increasing age, early menarche, low parity, tamoxifen use, obesity, and high-fat diet. Now, OCP, according to the book, it occasionally becomes a risk factor. Pregnancy also, and however, it's clearly indicated that smoking in a low BMI woman decreases the risk of leiomyoma. Why? Because smoking decreases estrogen. So a woman experiences a hypoestrogenic state, and therefore it decreases the risk of leiomyoma. However, you have to weigh benefits and the risks of smoking. Okay? So there you go. All right. Again, these are the factors that increase the risk of leiomyoma. So going back to this question, the answer should be smoking. Okay, so this is the pathogenesis of leiomyoma. There is noted to be an increase in the number of steroid receptors in the myoma. What steroid receptors are we talking about? It's the estrogen and the progesterone receptors. Now, the growth of the myoma is dependent on steroidogenesis. So how do we generate steroid? Okay, so here, estrogen is formed from aromatization, and it was found out that in the myoma, there is an increased expression of the enzyme aromatase. And so from cholesterol conversion into androstenedione and testosterone, aromatase enzyme causing aromatization produces more estrogen. So therefore, with increased receptor in the myoma, stimulation of an increased estrogenic environment causes growth of the myoma. So again, I showed this already earlier, the gross and the microscopic. So it's light in color, glistening. It's whorled, okay? Again, these are benign neoplasm. And so what we see in histology are mature, smooth muscle cells arranged in interlacing bundles. That's why it's spindle in shape. If there is more collagen, then it makes the myoma stiffer. So actually, these are gross photos of myoma, and these are the blood vessels feeding the myoma. Arterial supply is significantly less than normal, than the normal myometrium. And if this happens, degeneration occurs, okay? So it is the large blood vessels that feed the myoma. And so it's very common to see very bad looking blood vessels in very large myoma. However, if the blood supply outgrows or is lesser than the one it supplies, then the myoma undergoes degeneration. So hyaline degeneration is the mildest form of degeneration, and it appears homogeneous, while the carneous, red, or infarcted degeneration is the most acute form. This is painful, and so we can give NSAIDs to our patient. Remember, the three most common, 65% is hyaline, 15% myxomatous, and 10% of the leiomyoma degenerates as calcific degeneration in 10%. Is there a risk of malignancy? Actually, it's 0.3 to 0.7. It's not actually that the myoma becomes malignant. There is what we call the sarcoma, which occurs spontaneously. It appears like a leiomyoma, but it is more on older women at ages 60 years old, and there is a rapid growth. Therefore, if a woman presents in her sixth decade, there is rapid growth of what we thought as the leiomyoma, then we should suspect already sarcoma, okay, the malignant counterpart of the leiomyoma. Because remember, in the pathogenesis, estrogen feeds the myoma, but in postmenopausal women, supposedly, there's no more estrogen or progesterone feeding the myoma. So how do we diagnose leiomyoma? PE. The uterus is enlarged, firm, and if it's submucosal, it's irregular. Okay, it's like the Mickey Mouse. We can do ultrasound if the myoma is not very large yet and the patient refuses intervention, or it's too small to do an intervention, because again, leiomyoma can range from very small nodule to very large ones. So we can just do surveillance every 6 months. And for submucous myoma, we can do sonohysterography, hysteroscopy, hysterosalpingography. What to do? Well, it depends on 3 factors: age, future reproductive plans, and parity. I remember this as AFP, so you will not forget when you are trying to decide what to do on patients with myoma. Again, how old is your patient? What are her future plans of reproduction? Does she want to get pregnant? Does she not want anymore to have another pregnancy? And how many children she has had? Now, we have different managements, and one of them is myomectomy. And so I will be enumerating the indications of myomectomy. 1, persistent abnormal bleeding. 2, pain or pressure, enlargement more than 8 cm, who has not completed childbearing yet. Again, it's the F in AFP, future plans of fertility. While the contraindications for myomectomy are pregnancy. You cannot do myomectomy when a woman is pregnant. Advanced adnexal disease. If there's advanced adnexal disease, might as well get the adnexa as together with the intrauterine mass. If there is a malignancy, you cannot just remove the myomectomy and leave the malignancy behind. And of course, situation in which enucleation severely reduces the endometrial surface. So in these cases, it will not be advisable to do myomectomy because we will be destroying the endometrial surface if we proceed with enucleation on very large myoma, touching already a very big part of the endometrial surface. Our goal is to preserve fertility. And so if we destroy the endometrium, then it defeats the purpose. How about hysterectomy? When do we choose hysterectomy? When, again, like myomectomy, there is persistent abnormal bleeding, there is also pain or pressure, enlargement more than 8 cm among women who has completed childbearing. So again, if the myoma is large already and the woman has satisfied the F in the AFP, okay, so we can already do hysterectomy. Even among asymptomatic women, but the uterus is as large as more than 14 to 16 weeks age of gestation, then we can do hysterectomy already. And again, if there is rapid growth, because you want to rule out if this is not the malignant counterpart. There are also cases that the myoma can prolapse, especially in cases of pedunculated leiomyoma, pedunculated submucous leiomyoma. It can prolapse. No? What does prolapse mean? It can go even out of the cervix to the vagina, causing bleeding. So since it's in the vagina already, we can do vaginal myomectomy. We can twist it from the base, okay, or we have different surgical techniques. What I do is, if the base is just thin or the peduncle is very thin, I just twist it from the base and then give antibiotic coverage. However, if the base is thick or it's very thick, and so we have to use sutures and remove the prolapsing myoma. and then do curettage just to make sure that we don't leave anything behind. And of course, antibiotic coverage. We can also do uterine artery embolization. Apart from all those, we have options for medical management here. And worth to mention will be ulipristal acetate. It's a selective progesterone receptor modulator here, this part here, and acts on binding to the progesterone receptors in target tissues, thus displays antagonistic and partial agonistic effect. So as I said in the pathogenesis, steroid play a very significant role in the growth of the myoma. Therefore, if there is a selective progesterone receptor modulator such as the ulipristal acetate, then it can do its job of decreasing the myoma. Also, another is the aromatase inhibitor. As you can see in the process down below, aromatization plays a very significant role. And so we can give an aromatase inhibitor to block the synthesis of estrogen. So if ulipristal acetate is for progesterone, the aromatase is for the synthesis of estrogen. That is shown to reduce uterine fibroid size up to 71% in just 2 months. It also ameliorates uterine fibroid symptoms, reduction in menstrual volume, and duration of menstruation and urinary retention. Now, that's it for leiomyoma. We will proceed with adenomyosis, also very short, but very much related to leiomyoma. Just like the leiomyoma, we have the same objectives for this topic. Adenomyosis is referred to as endometriosis interna. Why? Because it's an endometriosis that invades the myometrium. Again, remember that the endometrium is the innermost lining of the uterus. And so when it extends into the myometrium, it becomes an ectopic endometrium. And we call it the adenomyosis or endometriosis interna. There is a direct extension from the endometrial lining to the myometrium. Important to mention that in 20% of the time, adenomyosis occurs with endometriosis. What are the components there? As I said, these are ectopic endometrial glands and stroma that upon low power magnification measurements, there is more than 2.5 millimeters of extension from the basalis layer of the endometrium. Okay, so let's see if I can annotate. I'll use the pen. So if this is the outermost layer of the uterus, inner layer. Again, remember this is the endometrium, okay? And this is the myometrium, okay? Supposedly, endometrial glands and stroma should just stay here. But with adenomyosis, it has gone deep to the myometrium. Okay? Also, it's worth mentioning that adenomyosis most of the time are incidental findings. No, 60% of hysterectomy specimens we can find or commonly find adenomyosis. Although prevalence can be just around 30%, surprisingly, 50% of these isolated adenomyosis cases are asymptomatic. Unless, again, it occurs with other conditions, the most common presentations are dysmenorrhea and menorrhagia. This is more common among 35 to 50 years old. And in fact, dyspareunia can also occur. It can be deep and in the midline. So this is one good drawing that I can compare to you how a normal uterus looks like and how a spongy uterus looks like because of the adenomyosis. So here are ectopic endometrial glands and stroma. Risk factors, increased parity, perhaps due to uterine trauma and surgery, because of curettage, cesarean section. Those things are considered risk factors. Unfortunately, up until the present, pathogenesis or the actual cause is unknown. But the most believable theory or proven theory is the disruption of the endometrial myometrial interface, and thus increasing parity and trauma to the uterus are risk factors in the development of adenomyosis. However, there are women, newly porous women, who still has adenomyosis, and so we are still studying the exact mechanism why adenomyosis happens. So pathology, there are two forms of adenomyosis. It can be diffuse, like the entire uterus. Most commonly, it's the posterior that gets more commonly affected than the anterior. It can also be focal, just like myoma. There's a pseudocapsule as focal adenomyosis. So here, as you can see, this is the posterior portion and the anterior portion. There is a symmetric thickening, okay? Meaning the posterior is thicker than the anterior. It's spongy. These are in the grossly, we look at the endometrial glands and stroma as spongy appearance. There can be hemorrhagic areas, cystic spaces, and blood within the cystic spaces. Also very common gross finding in adenomyosis. So this is diffuse posterior adenomyosis. Globular uterus, spongy myometrium. And under the microscope, we can see ectopic endometrial glands. So these are the endometrial glands, and these area are the endometrial stroma. Supposedly, we do not see endometrial glands and stroma in the myometrium. And so seeing this under the microscope gives us the diagnosis of adenomyosis. So clinical diagnosis, we only confirm it after histologic evaluation. But on pelvic examination, the uterus is diffusely enlarged, globular, and tender. Tenderness is usually appreciated before and during menstruation. As I mentioned again earlier, it can coexist with other pathologies such as endometrial hyperplasia or carcinoma, myoma, endometriosis, and salpingitis smica nodosa. Imaging techniques, in imaging, it shows a poorly defined junctional zone. Again, the junction between endometrium and myometrium. So we can do a simple 2D ultrasound, while MRI, because the physical examination finding is quite difficult to differentiate leiomyoma and adenomyosis, MRI is clinically useful in differentiating adenomyosis from uterine leiomyoma. We can also do hysterography. What to do? There is also known proven satisfactory medical management for adenomyosis. We have several medical managements mentioned here, similar to leiomyoma, but hysterectomy remains to be the definitive treatment. Again, consider the AFP, age, the fertility, future fertility plans, and the parity of the patient. How about if the patient opts to not treat adenomyosis and she becomes pregnant? So there are 3 risks associated with untreated adenomyosis and pregnancy. She is at risk for premature labor and delivery, a low birth weight infant, and preterm premature rupture of membranes. I guess this is my last slide. Thank you very much. And once again, good day. I'm Dr. Armero, discussing leiomyoma and adenomyosis.